Well, good afternoon. I apologize for some delay, depending on some technical problem. It's don't my responsibility. Okay, so now we'll discuss the ambulatory management of coronary artery disease. It's the classical picture of the person who experiences the severe substernal stabbing, squeezing pain, and that pain appeared after good meals. The guy goes out to the good entertainment, and it's a typical presentation of the angina with the typical localization of the pain, substernal pain, left side of the chest, with the radiating to the left arm. So, okay, some problem with sound presentation. I see the level looks not so bad. Well, and when they found coronary angiography, you see here the very significant stenosis of the left anterior descending branch of the left coronary artery, and everything is clear now. So, what is the problem? It is the insufficient oxygen supply, insufficient to oxygen demand, and this insufficiency depends on the failed supply of the myocardium with the blood due to atherosclerotic lesions and atherosclerotic stenosis of the coronary artery. What are the main features of stable coronary artery disease? I think it isn't a discovery for you, and the pathogenesis of it. It's the stable anatomical atherosclerotic and functional alterations of epicardial arteries and or microcirculation. And the natural history looks like stable symptomatic or asymptomatic phases which may be interrupted by acute coronary syndrome. And the mechanisms of myocardial ischemia is the fixed or dynamic stenosis of epicardial coronary arteries. The next mechanism is microvascular dysfunction, focal or diffuse epicardial coronary artery spasm, and all the above mechanisms may overlap in the same patient and change over the time. Clinical presentations: effort-induced angina caused by epicardial stenosis, microvascular dysfunction, vasoconstriction at the site of dynamic stenosis, and combination of the above. And the rest angina caused by vasospasm, focal or diffuse, epicardial, focal, epicardial, diffuse, microvascular, combination of the above. And asymptomatic, because of lack of ischemia endo left ventricular dysfunction, все, понял. Ну вот он больше пошел. Да, это наушники забивали и все. Окей. Well, I apologize. These technical problems follow us. Well, and at last, its presentation may be so-called ischemic cardiomyopathy, when we are not able to recognize the visible problem with the coronary arteries, but its result is the diffuse scarring of myocardium depending on the chronic myocardial ischemia. Well, you see here the pain patterns with myocardial ischemia. On the left side, you see the typical usual distribution of pain associated with myocardial ischemia. And on the right panel, you see the less common sites of pain with myocardial ischemia. So not so typical localization of the pain, but we have to take into account at last more typical presentation of the uh, chest pain. You see here, it's the traditional clinical classification of the chest pain. Typical angina. It meets all three of the following characteristics, like substernal chest discomfort or characteristic quality and duration, then provoked by exertion or emotional stress, and the third component is the relief of this pain by rest and or nitrates within minutes. Atypical problem, probable. So it meets two of these above presented characteristics. And at last, non-anginal chest pain lacks or meet only one or none of the characteristics. We traditionally use the classification of angina severity. We use Canadian Cardiovascular Society. It divides the severity of the angina in four classes. Class 1, when ordinary activity does not cause angina, such as walking and climbing stairs, and angina with strenuous or rapid or prolonged exertion at work or recreation. The next, class 2, it means the slight limitation of ordinary activity is the appearance of angina or walking or climbing stairs, rapidly walking or stairs climbing after meals or in cold, wind or under emotional stress or only during the first few hours after awakening, and walking more than 2 blocks on the level and climbing more than one flight of ordinary stairs at normal pace and in normal conditions. The next, class 3, it means the marked limitation of ordinary physical activity and angina on walking 1 to 2 blocks on the level or one flight of stairs in normal conditions and at a normal pace. And the last is the most severe uh, presentation of angina, class 4. It means inability to carry on any physical activity without discomfort. Angina syndrome may be present at rest. And you see here that chest pain is the tip of the iceberg in the case of myocardial ischemia. You see here clinical event, chest pain, but uh, in the bottom you see the ST change wave changes, uh, changes of systolic function, diastolic function, metabolic changes, changes of perfusion, and history with ECG, uh, radioventriculography, echo, uh, PET scan, perfusion scintigraphy, contrast tech, and so on. So you see here the cardiac event, like chest pain and history, these are just the tip of iceberg, which is uh, under these uh, events. Now we'll discuss the diagnostic approaches and the treatment methods of angina. At first, we have to recollect the understanding of the classes of recommendations and the level of evidence. So we use such classes of recommendations depending on the data of many randomized studies, and in some cases depending on the opinion of the medical community. So class 1, class of recommendation, uh, when the evidence and or general agreement that a given treatment or procedure is beneficial, useful, and effective. Sure, it's indicated and recommended. Class 2. In class 2, we sometimes meet conflicting evidence and or divergence of opinion about the usefulness and efficacy of the given treatment or procedure. So the preferable is class 2, when the weight of evidence opinion is in favor of usefulness and efficacy, should be considered. Class 2B, when the usefulness and efficacy is less well established by evidence opinion, but it may be considered. And at last, class of recommendation 3, when the evidence or general agreement that the given treatment or procedure is not useful, effective, and in some cases may be harmful. It is not recommended. And levels of evidence. Level of evidence A, when the obtained data derived from multiple randomized clinical trials or meta-analysis. Level of evidence B, it means the data derived from a single randomized clinical trial or large non-randomized studies. And the level of evidence C, it means the presence of consensus of opinion of the experts and or small studies, retrospective studies or registers. So, do we need resting ECG? Sure, in all cases, but you see here the classes of recommendation 1, but level of evidence C. I think it's obvious that a resting ECG is recommended in all patients at presentation. And it is recommended in all patients during or immediately after episode of chest pain suspected to indicate clinical instability of coronary artery disease. And you see here how works the ECG stress test after the physical exhaustion or pharmacological load, usually with dobutamine, maybe with lipiridamole. See here, before quite normal ECG and after the stress, it's, I think, was the physical exercise stress test treadmill. You see the typical depression of the ST segment. It shows us about the severe ischemia. Ambulatory ECG monitoring, Holter monitoring. for initial diagnostic assessment of stable coronary artery disease. You see here, it is superior if we try to reveal arrhythmias. But for suspected vasospastic angina, it is also useful. You see here the class of recommendation 2A, level of evidence C. You see here, how can we reveal the myocardial ischemia during the ambulatory ECG Holter monitoring? You see here, while the trivial physical activity, the patient demonstrates the significant episode of ischemia, depression of ST segment here. Holter monitoring, we talked about it, is useful for diagnostics of princemetal angina. The same names are angiospastic variant angina. You see here, during the pain, the ECG pattern looks like acute stage of MI, anterior MI, but in few tens minutes, you see complete normalization of the ECG. So how it may be presented resembling MI, but our task is to exclude MI with the serial registration of the ECG. Echocardiography. Class 1, level of evidence B. It is recommended in all patients to exclude alternative causes of angina, to identify of regional wall motion abnormalities suggestive of coronary artery disease, to evaluate left ventricular ejection fraction for risk stratification purposes, and to evaluate diastolic dysfunction. Sometimes the ultrasound of carotid arteries should be considered to be performed by adequately trained clinician to detect increased intima-medio ratio and plaque in patients with suspected stable coronary artery disease without known atherosclerotic disease. But the class of recommendations should be considered, yes, to A, level of evidence C. You see here how looks the stress echocardiography with dobutamine. Look, please, the letter 1, digit 1 shows the baseline level. It's the long axis of the left ventricle, short axis for chamber view to chamber view. And you can see that the quality of contraction looks quite good. We skip the initial stage of infusion of dobutamine intermediate. Please look on the digit 4. It's the final stage, and you can compare how the myocardium contracts at the finishing of the dobutamine. Initial stage, baseline, is quite normal contraction. After, you see the decreased contraction. You can compare digit 1, digit 4. Short axis for chamber view, digit 1, digit 4. We see here the decreased contractility to chamber view. Baseline, and after the injection, we simply confirm the idea about the coronary artery disease, because the injection of infusion of dobutamine provoked rather significant decrease of contractility of the anterolateral wall of the left ventricle. It confirms the idea about the ischemic genesis of such appearance. Chest X-ray, is it useful? Sure. It is recommended in patients with a typical presentation of suspicion to pulmonary disease, and it should be considered in patients with suspected heart failure. But what we can say, chest X-ray, it's the routine examination, we must take it into account. The next, when we use single photon emission computed tomography with 99 technetium systemib, and what we see, the rest rather good distribution of the technetium systemib, and after stress you see the significantly reduced perfusion of the myocardium. It's also the confirmation of the coronary artery disease with such ischemic changes. And the next one, you see here, is the positron emission tomography. And it shows the hibernating myocardium in patients having severe three-vessel coronary artery disease. What means three-vessel? Three branches: left anterior descendens, left circumflexa, and right coronary artery. Very significant decrease of the perfusion of the myocardium, and after the successful CABG, coronary allograft bypass grafting, the patient experienced dramatic improvement in left ventricular function. And now you can see how look the presentation of coronary artery disease with coronary angiography. Look please, it's the catheter, special catheter profiled to left coronary artery. It's the stem of the left coronary artery. And here is the division into left anterior descendens and left circumflexa. And you see here, before the bifurcation of the stem of the left coronary artery, very, very significant stenosis. This patient had a very high risk to die suddenly on the next day, or maybe on the next week, the next month, without any predisposing movement. Okay, so then this patient, after this investigation, was immediately operated with coronary allograft bypass grafting. This surgery was successful. The next one you can see here, another patient, rather significant 50% stenosis of the left main coronary artery, and practically 98 proximal left anterior descending artery stenosis. It looks like very, very, very thin thread here. So the same, the patient has significant clinical picture of coronary artery disease. The next one, another main branch, right coronary artery. We see here the complete discontinuation of the blood flow through the right coronary artery proximal part, and the filling of the peripheral part goes through some collateral arteries. Do we need some blood tests for routine assessment? Sure. And we have to control the level of lipids, glucose metabolism, and creatinine. And such panel of investigations is strictly recommended in all patients with known stable coronary artery disease. And we can compare the sensitivity and specificity of the tests, non-invasive tests commonly used to diagnose the presence of coronary artery disease. And you see here that exercise ECG, what we like, treadmill or valorgometry, has a rather low sensitivity but high specificity. The best result demonstrate exercise stress echocardiography, but it strictly depends on the level of skill of investigator and on some other factors like the quality of the baseline echo picture. And also we can use all the spectrum on these investigations. Mm, but in real practice, in our real practice, we give the preference to coronary angiography. It's really the strict method to uh, evaluate and define the degree of the damage of the coronary chart, coronary roadmap, and to make a decision about interventional method, surgery, or traditional medication or therapy. I want to pay your attention to this slide because it shows us the clinical pretest probabilities in patients with stable chest pain symptoms. And some people said that the coronary artery disease is the different disease in men and female population. Look here, please. In the rather young age, with the typical angina, the probability we speak about the clinical picture of typical angina, the probability of real angina is less in women, especially in atypical angina and non-anginal pain. And in general, in the age population, the prevalence of male is more and more higher than in women. So, like we joke, please take care of men because the probability of the real coronary artery disease in women is less. And we must take it into account, especially while evaluating some atypical clinical presentations in both groups. Moreover, look in atypical angina, moreover in non-anginal pain, the probability of the real angina in male population is higher. What are the risk factors for ischemic heart disease? We divide these factors in fixed factors, non-modifiable, major modifiable factors, and other factors. So, unfortunately, we meet many non-modifiable factors like age, gender, family history, ethnic group, and already established vascular disease. But we can influence on the major modifiable factors like smoking, good advice to give up to smoke, control of blood pressure, we are able to do so. We can control cholesterol level, lipid profile level, and we can modify the style of life with the exercising, with the healthy style of life. Nowadays, this style became more and more popular. And some other factors like we have to control diabetes, obesity, usually associated with sedentary lifestyle. Homocysteine, rather a hidden problem, may be social class, psychological environment, type A personality, exogenous estrogens. Remember, the female population is defended with estrogen levels. Why the incidence of coronary artery disease in female population is less. Alcohol consumption uh, also influence on the development of the coronary artery disease, but usually like the factor provoking hypertension and more significant arrhythmias, usually fatal arrhythmias. And some other medical condition, infections sometimes as well. And for better recognition, for better recollection of the main uh, points to manage coronary artery disease, stable angina, you can remember this rather simple rule. A, B, C, D, E. Like A, aspirin in anti-anginals, we mean nitrates. The next, usage of beta blocker and to control blood pressure. The next, C, to control cholesterol level and smoking. The next, D, diet and diabetes. And at last, education and exercise. Education means explanation how to live further, and exercising uh, how to control physical activity. What about the diet intakes? I think these rules are well known, like saturated fatty acid to account for less than 10% of total energy intake through replacement by polyunsaturated fatty acid. Transunsaturated fatty acid below 1% of total energy intake. Less than 5 grams of salt per day. From 30 to 45 grams of fiber per day from whole grain products, fruit, vegetables. At least 200 grams of fruit per day with 2 to 3 servings. So it depends on the uh, economical state of the patient and population as well. The same for vegetables per day, 200 milligram. Fish at least twice a week, one being only fish. What about the alcoholic beverages? It should be limited. In general, it's the European recommendations. Some people don't understand how it is possible to use 20 grams per day of alcohol for men. Well, okay, in general, strictly restricted. Blood pressure recommendation, threshold, level, I think everything is always office blood pressure, 140/90, home blood pressure, 135/85, ambulatory blood pressure, in general, daytime, nighttime, I think it is clear. Pharmacological treatment. General consideration. Optimal medical treatment indicates at least one drug for angina ischemia relief plus drug for event prevention. It is recommended to educate patients about the disease, risk factors, and treatment strategy. And it is indicated to review the patient's response soon after starting therapy. Classes of recommendation 1, level of evidence C. Angina ischemia relief. Short-acting nitrates are recommended. First-line treatment is indicated with beta blocker and or calcium channel blockers to control heart rate and symptoms. For second-line treatment, it is recommended to add long-acting nitrates or ivabradine or nicorandil or ranolazine according to heart rate, blood pressure, and tolerance. Class of recommendation 2A, level of evidence B. And for second-line treatment, rimetazidine may be considered. Class of recommendation to be trimetazidine is very popular in our country, the same as for meldonium. Both are indicated as doping medication for high level sports. I really don't know. Maybe they are really effective. And according to comorbidities tolerance, it is indicated to use second line therapies as first line treatment in selected patients. The next, angina ischemia relief continuation. In asymptomatic patients with large areas of ischemia, more than 10% beta blockers should be considered. And in patients with spastic angina, calcium channel blockers and nitrates should be considered and beta blockers avoided. Event prevention. Low dose aspirin daily is recommended in all stable coronary artery disease patients. You see here, class of recommendations 1, level of evidence A. Clopidogrel is indicated as an alternative in case of aspirin intolerance, practically the same level of evidence. Statins are recommended in all patients, and it is recommended to use EC inhibitors or ARBs in presence of other conditions like heart failure, hypertension, or diabetes. These drugs also are strictly recommended. So we summarize here on this slide medical management of patient with stable coronary artery disease. For angina relief, first line, we use short-acting nitrates plus beta blockers or CCBs to decrease heart rate. And we have to consider CCB dihydropyridine if low heart rate or intolerance contraindications, and consider beta blockers together with calcium channel blockers dihydropyridine if Canadian class of angina is higher than second. And the second line therapy, it may add or switch one line for some cases. We can see such drugs like avobradine, long-acting nitrates, nicorandil, ranelazine, trimetazidine. And consider coronary angiography with percutaneous coronary intervention, PCI. We consider stenting or coronary allograft bypass grafting cabbage, not some kind of vegetables. And for event prevention, we have to manage good, healthy lifestyle. We have to control of risk factors, educate the patient, and give on the routine basis aspirin, statin, EC inhibitors, or ARBs. The next slide, it shows the global strategy of intervention in stable coronary artery disease patients with demonstrated ischemia. So, if the patient has significant coronary artery disease, having ischemia of more than 10% of myocardial involvement, and on the optimal medication or therapy, we consider here two ways. If the patient, if revascularization is possible for this patient, we must take into account anatomical factor, single or multivessel disease, involvement of left main coronary artery, last patent vessels, chronic total occlusion, proximal LAD, syntax score. We must take into account clinical factors like age, gender, diabetes, comorbidities, fertility, LV function, tolerance of medications, clinical scores. Then technical factors, how it may be performed with cabbage or PCI, And local factors like volume, quality of center, operator, patient preference, local cost, viability, waiting list, and so on. And we have such a choice with cabbage, PCI, or hybrid intervention. And if revascularization is not possible, it's the decision of operator. If the patient has refractory angina, we can consider some novel methods, experimental methods like stem cell therapy, spinal cord stimulation, external counterpulsation, chronic pain syndrome management, and to reassess the drug therapy approach. And we have such a very wide spectrum of interventional methods, resembles the Swiss knife, like we can illustrate it. So it's the schematic picture how the coronary allograft bypass grafting can be performed. Here is the uh, mammary coronary bypass grafting with the usage of left internal thoracic artery with pedicle. And such grafting we use for most responsible artery, usually left anterior descendants. And for less responsible arteries, we use the venous graft, which also make the bypass of narrowing coronary artery. And you see here the schematic movie how does coronary allograft bypass grafting is performed. We take the part of saphenous vein and insert it like bypass of stenotic area here. And the next approach with the usage of arterial graft, you see here it is used from thoracic cavity and here connecting stitching with the patient's coronary artery. And how looks schematically the stent implant procedure when the operator inserts the stent on the balloon. The balloon is inflated and at the site of coronary artery narrowing, the stent then support the coronary blood flow. And how looks coronary angioplasty with the stenting? You see here the 90% blockage of the left anterior descending branch of the left coronary artery. And this patient experienced the severe episodes of angina and the 30 millimeter long drug-eluting stents guided into place along the wire in the LAD coronary artery. It's a wire-guided stent. It is placed on the position of when the artery was narrowed by atherosclerotic plaque. Stent is expanded to full size with the balloon inside the catheter. And now you see the complete restoration of the coronary blood flow as the result of the successful PCI, successful percutaneous coronary intervention. You see the complete restoration of coronary blood flow. And here are the frozen pictures. How here is the right coronary artery. Before percutaneous transluminal coronary angioplasty and after performing this procedure. And the same, not same, but it's the patient severe narrowing and the result of angioplasty. So we simply repeat this slide. You see here all the facilities we can use for treatment. What about the follow-up or ambulatory management of the patient with the stable coronary artery disease? It is recommended that all revascularized patients receive a secondary prevention and be scheduled for follow-up visit. And it is recommended to instruct patients before discharge about return to work and reuptake of full activity. Patients have to be advised to seek immediate medical contact if symptoms occur or reoccur. Antiplatelet therapy. Single antiplatelet therapy, usually aspirin, is recommended indefinitely. A double antiplatelet therapy, DAPT, is indicated after bare metal stent for at least 1 month. Double antiplatelet therapy is indicated for 6 to 12 months after second generation drug-eluting stents. And double platelet therapy may be used for more than 1 year in patients at high ischemic risk, as stent thrombosis, recurrent acute coronary syndrome on double antiplatelet therapy, post-MI, diffuse coronary artery disease, and low bleeding risk. But you see, class recommendation may be considered to be. And double antiplatelet therapy for 1 to 3 months may be used after drug-eluting stents implantation in patients at high bleeding risk or with undeferrable surgery or concomitant anticoagulant treatment. But in general, in our days, it is better to recommend to continue double antiplatelet therapy for everybody having already stents. Perform it up to 2 years. Then, imaging management. In symptomatic patients, stress imaging like stress echo, MRI, or some other procedures is indicated rather than stress ECG. But sure, it depends on the medical facilities which are available or maybe not available. In patients with low-risk ischemic findings, less than 5% of the myocardium at stress imaging, optimal medical therapy is recommended. And in patients with high-risk ischemic findings, more than 10% of myocardium at stress imaging, coronary angiography is recommended. Late, after 6 months stress imaging test after revascularization may be considered to detect patients with restenosis after stenting or graft occlusion, irrespective of symptoms. But in general, the absence of angina attack after the stenting is the good prognostic factor. It usually shows us that the stent works properly. And after high-risk PCI, late from 3 to 12 months control angiography may be considered irrespective of symptoms. And what about the systematic control angiography earlier or late after PCI? It is not recommended in general. Well, you see here, how can we choose PCI or CABG in stable coronary artery disease patients without left main coronary artery involvement? Remember, please, that the involvement of the left main coronary artery, it practically in all cases means the indication to CABG without any additional consideration. So, number of coronary arteries with relevant stenosis in proximal segment. Single, lesser, or two vessel disease with proximal left anterior descendants branch involvement. If no, we consider PCI. If yes, hard team discussion. Can we perform PCI or if we need CABG? And when the syntax score is below 22 in three vessel disease, the same hard team discussion we need. When the syntax score is more than 23 with low surgical risk, we consider the CABG. And PCI or CABG surgery with left main coronary artery involvement. So, one vessel disease, osteo, mid, shaft, distal, osteo, mid, shaft, high surgical risk, so we have to avoid CABG. Distal bifurcation, we have to discuss it. And if the patient has two or three vessel disease with syntax score more than 33, if low surgical risk, CABG. If syntax score below 33, to discuss. What are the treatment options in refractory angina? Class 2 of recommendation. It is enhanced external counterpulsation. It should be considered for symptom relief in patients with invalidating angina refractory to optimal medical and revascularization strategies with the class of recommendation 2A. Two other approaches like transcutaneous electrical nerve stimulation or spinal cord stimulation, it may be considered to ameliorate symptoms of invalidating angina refractory to optimal medical vascularization strategies. Both approaches, but class of recommendation is 2B, may be considered. And at last, transmyocardial revascularization is not indicated in patients with invalidating angina refractory to optimal medical and revascularization strategy. We remember the times when such an approach provides good perspective for such method, but nowadays we now completely refuse of it. Before to say goodbye, I want to recollect this simple rule, like the usage of this ABCD rule, like aspirin, anti-anginals, beta blockers, and blood pressure control, control of cholesterol and cigarette smoking, diet, appropriate diet and control diabetes, and to educate, explain the patient and perform the exercise and physical exercising. Now I want to say take care and goodbye. If you have Some questions you may ask. So now I want to say goodbye once more.